All right, our next presenter is Dr. Catherine Unverferth. Dr. Unverferth is the medical director of the UCLA Maternal Mental Health Program, overseeing the perinatal intensive outpatient program, the perinatal partial hospitalization program, as well as serving as the co-director of the UCLA Women's Life Center. Dr. Unverferth is an expert in reproductive psychiatry and has been involved in the creation of the National Curriculum for Reproductive Psychiatry. She co-created the module on premenstrual mood symptoms for the NCRP, co-authored a chapter on PMDD in the APA textbook, and is a peer reviewer in reproductive psychiatry for Current Psychiatry. Please welcome Dr. Unverferth for her lecture on depression in pregnancy.
Oh. Hi, everyone. Thanks for making it to 4:45 on a Friday with me. I'll try to make this talk really applicable. This talk, it's going to focus on a very specific area of reproductive psychiatry, namely how you treat depression in pregnancy and what you do if somebody is on antidepressants or might need antidepressants. It stemmed from a colleague of mine who actually sent me a text. I get texts from a lot of colleagues asking what he should do with a patient who was pregnant. And while he was very thoughtful in what his plan was, it was somewhat misguided. And so we'll actually go over that at the end. And so we'll go over the basics of how you would manage a patient like that. Okay? Great. I don't have any disclosures. Objectives, basically what we talked about, right? So become familiar with the risk factors for antenatal depression, recognize that pregnancy is not a protected time. I think that's really important. I'm sure most of you are aware, especially for the patients that we're treating, patients with a history of depression. Pregnancy is not a protected time from a psychiatric perspective. Understand the guiding principles of treatment, and describe the risks and benefits of common antidepressants in pregnancy. I also want to say that I am going to use the term woman in this talk, but by that I mean somebody who was assigned the female sex at birth, but that can include cisgender women, transgender men, and non-binary people, but I will use the term woman, okay? Definitions, main thing from this is that antenatal depression is depression during pregnancy. I just want to make sure we're all clear on that and there's no confusion. Prenatal is the same as antenatal, but prenatal sometimes is used to refer to the time before conception as well. Perinatal is before and after birth. So if you've heard of perinatal psychiatrists, those are psychiatrists who deal with women who are interested in becoming pregnant, are pregnant, or in the postpartum. Postpartum is about 1 year after birth, and postnatal is the same as postpartum. Okay, moving on to background. So the prevalence of depression. So we know that women are twice as likely to experience depression as men over the lifetime. There are some studies that show that women and men have the same risk for depression until puberty, at which point hormones come into play for women. At that point, the women's risk increases and remains elevated until menopause, at which point hormones go out of play. So there is some thought that there's a hormonal contribution to this increased risk of depression. During pregnancy, it's said that about 10 to 15% of women will experience depression. If you're looking at symptoms of depression, that number is much higher, but I would say about 10 to 15%. One of the most important things that I want you to get from this talk is that pregnancy is not a protected time, okay? So I think there used to be this idea that pregnancy was a protected time from a psychiatric perspective, that the woman was glowing, she was blissful, this was like she was happy to be pregnant, right? And we know, and while that might be true, for women with a history of depression, pregnancy can be a difficult time. They can have relapse into that depression. And so there were 2 studies that looked at what happened with women who discontinued their antidepressants when they found out they were pregnant, or continued their antidepressants, because people were trying to figure out what to do. And so the first was by Lee Cohen and colleagues. It was a prospective cohort study. Most of them are, so it's a group of people and they follow them forward in time. It was 200 women with about 3 months of euthymia, so who had been stable, right, who had been doing well. They were recruited from psychiatric clinics, and I think that's important because that means it's probably a more chronically ill population, right, than what you would typically see in like your OB or PCP's clinic. And what they did is half tapered off of medications and half continued on medications. And what was really interesting is that even though those women had been stable for 3 months before, those who tapered off of their medications relapsed at a very high rate, so 68%. So 2/3 relapsed into depression during pregnancy. Those who continued on their medications still relapsed at 26%, so almost a quarter. And so from this, I think for our chronically ill with recurrent depression patients, they need to be counseled about the risks of coming off of medications. And that's why I'll get into it later, but when you're doing an assessment with somebody who wants to become pregnant, who wants to come off of their medications, you need to understand what the risk for them is if they relapse into a depressive episode, right? For some people who have mild depression, they might be willing to accept that risk. But for people with moderate to severe depression who might have suicidal ideation or past suicide attempts, that's not necessarily a risk you would want to take, okay? This is just the same thing illustrated. So we see on the top line, those are people who maintained their medications. They relapsed at a lower rate. On the bottom line, those who discontinued their medications, they relapsed at a much higher rate. There was another study with a less ill population. So this was by Kimberly Yonkers and colleagues. It was about 800 women recruited from hospital and community prenatal care sites. So again, these are not psychiatric clinics. They excluded women currently experiencing depression. Some women stayed on medication, some women came off of medication. But the main thing from this, and I think what it affirms what we saw before, is that depression, MDD episodes 6 months before pregnancy, and a history of greater than or equal to 4 prior depressive episodes were risk factors for MDD during pregnancy. So the same thing. So women with a history of recurrent depression are likely to experience depression during pregnancy. Okay, so other risk factors. So history of psychiatric disorders, like we talked about. Domestic violence. We know that interpersonal partner violence can get worse during pregnancy and in the postpartum as a third person is kind of added to the dyad. Life stress, negative life events. COVID, right? COVID is a huge stressful life event. You know, we know that rates have gone up. Low socioeconomic status, like we talked about before. Anxiety during pregnancy. In my clinical experience, the kind of psychological characteristics of people who I think do experience a lot of anxiety during pregnancy are those who like to be in control. I think it's not hard to understand how pregnancy can be experienced as a loss of control over your body, right? Something is, you're growing, you're changing, and for some people that is extremely difficult. Other people, health anxiety, of course, right? People with health anxiety have a lot of trouble with the doctor's visits and the checkups and waiting for test results. Those are things. Smaller inconsistent associations, poor social or relationship support, young maternal age, or unintended pregnancy. There's some thought that PMDD, premenstrual dysphoric disorder, might also be a risk for postpartum depression specifically, but that they might all be interrelated. So there is some thought that there's a reproductive subtype of depression. That's why what we see is premenstrual depression, PMDD. So that's when certain people, certain women have abnormal responses to normal levels of changing hormones. So in PMDD, we know that in the luteal phase, for those 2 weeks, sometimes people will experience irritability, anger, mood symptoms, mood swings, physical symptoms, but they don't have different levels of hormones. They just have abnormal responses to normal changing hormones. And we see that we think that postpartum depression might be the same thing, right? Postpartum depression, estrogen and progesterone go up during pregnancy and then drop off really quickly in the postpartum. And so some women, that might trigger a depressive episode, perimenopausal depression. There's some thought that weaning, when you're breastfeeding and then stop breastfeeding, that might also trigger a depressive episode. We know that there are hormonal changes there as well. So there's some thought that these are all related, and there might be a reproductive subtype or a hormonal subtype of depression. So sometimes we'll screen for that as part of a pre-pregnancy consultation, just to try to get a sense of how sensitive somebody is to hormonal changes and what their risk might be for depression during pregnancy or depression in the postpartum. So we know that 10 to 15% of women will have depression during pregnancy. We know that women with a history of depression are at higher risk. We know some other risk factors. The other really important thing to know is that depression during pregnancy is not benign. I think that some people have this sense that it's better to grin and bear it. You know, if you can just get by, that's better, even if you're depressed. And we know that that's not true. So the negative pregnancy outcomes that have been consistently associated are preterm birth, low birth weight or small for gestational age, and decreased breastfeeding initiation. There's some really, really interesting studies with breastfeeding that shows that women who are depressed experience breastfeeding as more painful and have less of an oxytocin release. I think it's really fascinating, actually. But it explains like what might be going on here too. Additionally, people, whenever you think about using an antidepressant during pregnancy, patients are very worried about neurodevelopmental outcomes, right? But what I think they don't really grasp is that untreated depression during pregnancy has negative neurodevelopmental outcomes, right? So we know that moms who, like infants or children of moms who were depressed during pregnancy have developmental, social, and behavioral problems. We know that there are brain structural and functional changes in children, like including changes in connectivity between the amygdala and hippocampus. We know the amygdala is involved in emotions. There was an interesting study that showed that cytokine signaling was changed, so some kind of immune system response was changed. And you could see that 45 years later. So again, not benign. We also know, and something I do talk about with my patients is, what are you like when you're depressed? Are you eating healthy? Are you exercising? Are you going on walks? Are you talking to friends? Are you functioning well at work, right? We know that there are all of these behavioral changes associated with depression that are hard to control for, but are also really important during pregnancy, right? So if we give you a little bit of fluoxetine, right? Are you going to get out of bed? Are you going to eat that, avocado and have a green smoothie? Are you going to do these things that are good for you? I think that's really important. And we've also seen people who are like smoking a little bit of marijuana to try to get by during pregnancy, right? Or using substances instead of taking an antidepressant, which might be more helpful, right? So we can't forget the associated behaviors. As if that weren't bad enough, we also know that depression during pregnancy is probably the biggest risk factor for postpartum depression, okay? And postpartum depression, also not benign. So postpartum depression has been consistently associated with negative neurodevelopmental outcomes for the child. So we know that there's impairment of cognitive function, behavioral disturbance, poor physical health, insecure attachment, and depression in the offspring. And I think on some level, it's relatively easy to visualize this, right? We can imagine that a depressed mom is going to be more internal, right? It's going to be harder for her to respond to the infant, right? And a lot of the way infants' development is that reciprocal interaction, right? So if a depressed mom isn't able to provide that reciprocal interaction, it does affect things. And so the way we would say that is less affectively positive and less mutually responsive. And so I think you can see where intervention can be so important, right? Because if we have that mom feeling better, that can actually change the child's trajectory. So additionally, it looks like postpartum depression may begin for about a third during pregnancy. So sometimes we'll see that in the third trimester, people will become depressed, and then that carries over into the postpartum. So intervention is important. I just saw a physician patient near the end of her third trimester, severely depressed, didn't want to take medication, but had a very severe postpartum depression in the past. And so one of the ways that we talked about and I got her on board with taking medication was because she was putting herself at extremely high risk for postpartum depression by allowing herself to continue being depressed during pregnancy. Okay, so summary. So 10 to 15% of women will have depression during pregnancy. For women with a history of depression, pregnancy is not a protected time. Tapering off of antidepressants probably increases the risk. Antenatal depression has negative outcomes. Not treating is not a risk-free situation, okay? So no grinning and bearing it. right? And so this brings us to this idea of the risk-risk situation, and reproductive psychiatrists will often talk about this. So you basically have to weigh the risk of untreated depression versus the risk of the medication. And so that's what you're trying to balance. It's not medication or no medication, it's depression versus medication. Okay, so now we're gonna move on to decision making. So when I take a history for a pre-pregnancy consultation, I often tell people to start at the beginning. So how was growing up? How was your relationship with your parents? When was the first time you had depression or anxiety? How did you handle it? What medications did you take? I'm trying to assess for a few things. I think when you're assessing for whether or not they should stay on medications, what you're trying to see is, have they had any periods where they've done well without medications, right? Somebody who has never been able to sustain for more than a few months at a time being off of medications, it's probably not going to happen during pregnancy, right? If they've had years where they've been off of medications, but fluoxetine just takes the edge off, maybe they could do it, right? So you're really trying to understand that. You're also trying to understand how bad could it be if they have depression during pregnancy, right? Somebody who's been hospitalized, somebody who had suicide attempts, I'm not sure that's a risk that's worth it. Other things, you think about their age. Is there time for a trial off of medications? I think partially based on the Kimberly Yonkers study that I talked about, where they said depression in the 6 months before pregnancy was a risk factor for depression during pregnancy. Sometimes we'll recommend 6 months of euthymia before getting pregnant because we feel that kind of stability predicts stability. So if you want to change your medications, that's completely fine, but we would love for you to be on those medications for 6 months before you get pregnant. Obviously, that's an ideal situation. Not everybody wants to do what you would recommend. It's fine. And if they're older, you wouldn't necessarily recommend that. You want to know about the OB history. You're wondering about, have they had a prior miscarriage? Prior adverse infant outcomes are important too, because that really affects their tolerance for risk, right? So if they've had a negative infant outcome before, they might not want to take an antidepressant because of concerns about risks. And you have to understand that. You have to meet them where they are. Past psychiatric history, of course. I think something else that's really important to talk about and screen for is trauma. Pregnancy often brings up traumas, right? I think if the repeated medical visits, the invasive repeated medical visits, delivery can be experienced as very traumatic and kind of dehumanizing sometimes. And then postpartum, you have this new, perfect, incredibly vulnerable infant. And so for people with a history of trauma, it's often brought up and brought very to the forefront in ways that surprise them. And so if, on my evaluation, if they have a history of trauma and they've never done trauma work, it's one of the first things I recommend, okay? Social situation and supports, that's obviously important, right? You can't do it by yourself, but some people think they can. And so you want to assess that really early and try to kind of help them shore up their supports. And then breastfeeding desires. We know that breastfeeding, if you're exclusively breastfeeding, it essentially requires sleep deprivation, okay? And so some people don't think about that. They're just like, I'm gonna breastfeed, I'm definitely breastfeeding. And then you'll ask them, you'll be like, well, how do you tolerate sleep deprivation? They'll be like, terribly, terribly. And when they say that, you have to start thinking with them, like, how are we gonna manage this then? Like, I understand you want to breastfeed, and I understand you want to sleep, and in some ways those are not compatible. So sometimes what we'll recommend is we'll recommend pumping, so somebody else can give a bottle overnight. Sometimes we'll recommend supplementing with formula overnight, just thinking of ways to maximize their sleep. But those conversations start early. That's not what you want to have in the late third trimester when they've been dreaming of exclusively breastfeeding the whole time. So the guiding principles of treatment during pregnancy. So it's this risk-risk situation. So when we say that, what we want to do is you don't want to get an exposure to both of the risks. So essentially, if I'm going to use a medication, I want to use it at an effective dose. So if you're using fluoxetine 10 during pregnancy and somebody is still having clinically significant symptoms of depression, you're getting the exposure to the medication and to the depression. That's not what we would recommend. So what I would recommend is you increase the fluoxetine so that decreases the depression symptoms into remission, okay? So that's really important because you only want to get the exposure to one if you can. And again, I see this sort of selflessness that pregnant women sometimes have, where they're like, I can do it, I'm mostly fine. But they're not that fine, and they think that it's better or safer to be on fluoxetine 10 milligrams. But we don't really have evidence that lower doses are safer, and it's more important to kind of help their depression go into remission, okay? You want to minimize the exposure to multiple medications. So for example, if someone is on escitalopram and trazodone, right? And they're on low doses of both, what you might try to do is see if you can raise the escitalopram, the Lexapro, and taper them off of the trazodone and add in a course of cognitive behavioral therapy for insomnia. So if you can, we recommend kind of paring down the medication regimen, just because most of the studies are on individual medications, right? They're not really on medication combinations. Sometimes they have unexpected results. So if you can, paring down the regimen within reason. This is also, I keep saying like, this is really important, this is really important. This is also really important. If a patient gets pregnant on a medication, the decision of which medication to use during pregnancy has been made. We have a lot of data on the SSRIs, SNRIs, Wellbutrin, right? We have enough data pretty much to feel comfortable using those during pregnancy when they're indicated. So if somebody gets pregnant on venlafaxine, the decision of which antidepressant to use has been made, unless it's not working, right? If it's not working, that's a different situation. But if it's working well, we don't recommend changing it. We can get into this more, but I think there has been a sense in the field that sertraline is the safest and that it's like that's the best one for pregnancy. And while that might be true in somebody who's medication naive, the best medication is the one that keeps the woman stable. So if somebody hasn't responded well to SSRIs, but they respond well to SNRIs, I certainly wouldn't recommend putting them on a medication that's not going to work, right? Yeah, and then the best time to plan medications during pregnancy is before conception. So there's an interesting statistic that 85% of women 40 to 44 will have a child. That like by that time, they'll have a child. Sorry. By the time they're 40 to 44, they'll have a child. Not everybody's having babies at 40, although that is becoming more common. So I think when you're treating women of reproductive age, that's really important to take into consideration, so that if you're treating them over the course of their lifespan up until they're in their 40s, it's very likely they're going to get pregnant on these medications. And so it's important to think about that before you start, 5 different medications at lower doses, right? Okay, I'm gonna say it again. If the antidepressant is used during pregnancy, do not recommend changing it in the postpartum. So essentially, any antidepressant that you use during pregnancy, you can use with breastfeeding, okay? The American Academy of Pediatrics says that breastfeeding on antidepressants is not contraindicated. There was this really nice review article that looked at national and international society guidelines, and almost across the board, they recommending breastfeeding regardless of antidepressant used, okay? So there's no reason to change an antidepressant that's been working in the postpartum because of concerns about breastfeeding, period. Additionally, we think that exposure in utero is kind of effectively 5 to 10 times higher than during breastfeeding. And if you were to want to switch for some reason, which again, I don't recommend, what you're doing is you're kind of at a vulnerable time, because the transition from pregnancy to postpartum is a vulnerable time. You're exposing the woman to more risk and changing to a medication that we don't know it's gonna work, right? So again, we wouldn't recommend that. If somebody becomes pregnant on a medication, it's okay. It happens all the time. In 2011, 45% of pregnancies in the US were unplanned. So about half of pregnancies are unplanned, and most people are going to be pregnant. It's typically around 5 to 7 weeks gestation. And it's a time where you talk with them about what they want to do. In my mind, it's typically a time to try to pare down the medication regimen if you can. So again, that patient that's on escitalopram, Klonopin, and trazodone. What can we take away? What can we use PRN? What can we maximize? That's typically how I think about it. It's rare that I would agree to taper it. Usually if we're tapering a medication, we would taper it before. If the person feels very strongly that they can go without it, then okay. I think that it has to be a conversation about what the risk could be, though, because we know that people who taper around the time they find out they're pregnant have a high risk of relapse, especially if they've had recurrent depression. Yeah, I think I covered all of that. Oh, and just don't abruptly stop it. Some people are pregnant, they stop everything. We would still recommend tapering it, okay? Okay. All right, moving on to antidepressants during pregnancy. So we'll talk about some more specifics here. One thing I will say before we get into this is when you use an antidepressant during pregnancy, sometimes you do need to increase the dose over the course of the pregnancy. So we know that people get physically bigger, their volume of distribution increases, and their metabolic rate increases. So it's not uncommon that in the second and third trimester, you need to increase it just to maintain the same therapeutic response, okay? Okay, so caveat about these studies we'll go over. The biggest thing is confounding by indication. So confounding by indication means that the indication for which the medication is used causes the negative outcomes. So it's essentially, we know that depression during pregnancy causes negative outcomes. When you add a medication, it's hard to suss out what's due to the depression and what's due to the medication, okay? And that is something that comes up in this field over and over again because it's very hard to see if it's the underlying condition that's causing the outcomes or is it the SSRI, okay? Part of the reason it's complicated is because placebo-controlled randomized trials are unethical because untreated depressed pregnant women have worse outcomes. So we can't have the placebo-controlled trial would be depressed, untreated pregnant women versus depressed, treated pregnant women. But we know that these people have negative outcomes, so it's unethical to do those studies. We're never going to get those studies in this field. The other thing is that we can't infer any causation. We can only infer association. So everything I talk about is associations. Most studies are observational, so a lot of prospective studies or retrospective studies that rely on self-report. So it's really hard. People who take medication during pregnancy are different than people who don't take medication during pregnancy. So we can imagine that those who take medications during pregnancy have more severe mental health issues than those who don't. And so comparing those groups is complicated sometimes. We also know that those who aren't depressed have different behaviors than those who are depressed, so it's a little murky. And then limited studies on effects of multiple medications. So we have a lot more information about individual medications than we do about multiple medications. So the 4 outcomes that we are going to talk about are teratogenicity, pregnancy outcomes, neonatal outcomes, and neurodevelopmental outcomes. When we are talking about teratogenicity, I think it's very important that you tell your patients that the baseline risk of major congenital malformations with any pregnancy is 3 to 5%. It's important for them to know that. I think some people think it's 0. It's not, right? With any pregnancy, there's a risk of major congenital malformations of 3 to 5%. So when we say that SSRIs, SNRIs, Wellbutrin, TCAs don't increase the risk, what we're saying is they don't increase the risk of major congenital malformations above that baseline risk. So there's still a risk, but the antidepressants don't seem to add to it, okay? The big study that looked at this was Krista Hubricks and colleagues. It was a Medicaid population-based cohort study. They did propensity matching. Propensity matching is one of the best ways that we have to sort of adjust for depression severity and control for depression. And when they adjusted for the diagnosis of depression and depression equivalents, they found no increased risk of cardiac malformations. There are other studies. Cardiac malformations are the most common type of malformation, so that's often why they look at them. This study also found no significant association between the use of paroxetine and right ventricular outflow tract obstruction. So you might be aware, there was early data that said that paroxetine might increase the risk of heart defects. There's newer data that doesn't support that. That being said, often people avoid it during pregnancy still from more of a medical legal perspective than like an actually data-based perspective. So this is great, very reassuring. Here we have this data illustrated, and you can see that there were no significant risks, right? The confidence interval crosses 1. This is great. When we're looking at pregnancy outcomes, the data is similarly reassuring. So women who take SSRIs have similar rates of miscarriage as those who have depression. Good. The length of gestation. In the US, the preterm birth rate is about 7.5%. When antidepressants are used in the second and third trimester, there is shortened gestation, but it's a few days. It's not considered clinically significant, and I'm not convinced it's not residual confounding. With birth weight, antidepressant use is associated with lower birth weight, but so is depression. So again, wondering if it's residual confounding, even if it's real, it's a few ounces and it's not considered clinically significant. Other than that, we don't think that SSRIs, SNRIs affect pregnancy outcomes. The one thing we do talk about is neonatal adaptation syndrome. This is not pure neonatal withdrawal. Many people are worried about this, but this is an adaptation syndrome. It's typically mild, it's self-limited, it occurs in 15 to 30% of neonates. Some will say 0 to 30% of neonates because studies are conflicted. With serotonergic antidepressant exposure. It sometimes occurs for a few hours, at the longest a few weeks. But the caveats is that there was a really interesting study that looked at women who took continuous SSRIs versus those who were continuously depressed during pregnancy, and they found no difference in the rates of neonatal adaptation syndrome. So they suggested that maybe there was a different neurobiological disturbance going on. There also used to be this idea that if you taper in the third trimester, like if you avoid antidepressant exposure in the few weeks before delivery, that would decrease the risk for neonatal adaptation syndrome. That's not true. So there was a study where they looked at infants who weren't exposed in the last 2 weeks before delivery, and there was no difference in the rates of neonatal adaptation syndrome. So we don't recommend tapering before delivery. That was an old recommendation. Okay. Another reason we don't recommend tapering before delivery is if you do that, you're putting the mom at much higher risk of postpartum depression, okay? So the symptoms include insomnia, changes in muscle tone, agitation, tremors, restlessness, irritability, poor feeding, vomiting, diarrhea. The APGAR scores, there was a study that showed the APGAR score difference was 0.2, which is minuscule, right? So generally, this is very clinically insignificant. It's not a reason to withhold treatment, but it is something to mention. So we recommend additional 48 hours of monitoring in a special care nursery. Persistent pulmonary hypertension of the newborn comes up. PPHN is a potentially fatal condition of the neonate. Though the mortality rate now is 5 to 10% in developed countries, it used to be much higher. There was a large 2015 study also by Krista Hubricks who compared depressed treated women with depressed untreated women and did find a small, statistically significant increased risk with SSRIs. However, the baseline risk is very small and the absolute risk is very small. So if this is a true risk, the risk is still less than 1%. The FDA put out an advisory in 2011 that they updated in 2018, and they basically said you don't need to alter your practice of treating depressed pregnant women because of this very small risk. So at this time, FDA advises healthcare professionals not to alter their current clinical practice of treating depression during pregnancy. So again, something to mention, but not a reason not to prescribe. Neurodevelopmental outcomes have been largely reassuring. There was this great giant systematic review by Rommel. It examined 18 studies and it found no consistent associations with maternal antidepressant use and cognition, behavior, IQ, speech, language, and scholastic outcomes in children when studies are adjusted for confounders. So that's really good. So we know that depression can cause negative outcomes with that, but it doesn't seem like SSRIs do. Autism, I know that this came up earlier today, so I want to dive into it a little bit. Previously, there was concern for increased autism spectrum disorder with in utero exposure to antidepressants. It was 2 observational studies. They got creative with more recent studies to try to address the confounders. And so one study, they restricted the analysis to mothers with depression, and they compared antidepressant-exposed siblings versus unexposed siblings and saw what the rates of autism were, and there was no association. So they had the same rates of autism. There was another study that looked at women who received an SSRI before pregnancy. So this was them trying to look at the effect that depression has. So SSRI before pregnancy, when it can't have an effect on autism, and it did. Or the SSRI didn't. Sorry, that was a confusing way of saying that. When they looked at SSRI exposure before pregnancy, they also found an association with autism. And what that points to is that there are other factors outside of the SSRI that increase the risk. I think what's important here too is that maternal psychiatric illness is also associated with autism. So our current understanding is that while antenatal antidepressant use and autism are associated, when you control for confounders, such as genetic predisposition and maternal depression diagnoses, this association decreases and remains no longer significant. So essentially, we think that there may be genetic factors or environmental factors that are contributing to this, but that it's not the medication. Okay, so we're on to cases. So this is the text I got from my colleague. So I'm seeing a new patient who will be 29 weeks gestation at the time of our appointment. She is on venlafaxine 150 milligrams extended release, I think has been the whole pregnancy and for 10 plus years, and will want to be on sertraline by the time she has the baby, I'm assuming, so she can breastfeed. Okay, so let's dissect that. So the first thing is he has a 29-week gestation patient on venlafaxine 150 milligrams that she's been on for 10 years. It sounds like she might need the venlafaxine, right? Truly. So I think it's great that she's on the venlafaxine and pregnant, right? It sounds like she needed it. She will want to be on sertraline by the time she has the baby, I'm assuming, so she can breastfeed. And I think this is the mistaken assumption that sertraline is significantly safer than venlafaxine, or that the risk of relapse from switching from venlafaxine to sertraline is somehow worth it, right? We do know that sertraline has very low levels in breast milk and is undetectable in the baby. And for treatment-naive patients, it is the first choice for postpartum depression. But for people who have been in kind of the psychiatrist's office for most of their life, we don't want to just go to medications that aren't going to work, right? So we feel like venlafaxine is compatible with breastfeeding. Most of the antidepressants, too, have relative infant doses. They use this term. It's like a weight-adjusted dose of less than 10%. And that's typically the cutoff that's used when you say that something is safe for breastfeeding. Yeah, we'll leave this there. So he goes, I would typically start the new SSRI prior to tapering venlafaxine to help with withdrawal, but would rather not have a pregnant woman on 2 antidepressants. So that's good, I agree. There's no reason for somebody to be on 2 antidepressants if they can be on 1 antidepressant, right? It's still showing the sort of mistaken assumption that it would be better to switch, right? And then he says, I was also thinking of timing the taper to have her off venlafaxine by 37 weeks, but then starting sertraline right after the baby is born rather than earlier to avoid neonatal withdrawal. And so here, I think this illustrates, the not uncommon assumption that the neonatal adaptation syndrome is a preventable withdrawal syndrome, and it is not. We do not completely understand what it is. There might be a component of withdrawal in it, but it's not. Tapering doesn't decrease the risk for it, and I think that's really important. I think people also get very nervous with venlafaxine because many patients have experienced how terrible that withdrawal syndrome is. And so I find that those patients who are very sensitive to withdrawal are often very worried about the adaptation syndrome. And you can understand why, but when you explain to them what we know about it, it does help. Okay, so I made a chart. So the stars are his assumptions. So the correct assumptions, you want to minimize the exposure to multiple medications. Yes, right? If you can use one, use one. If you need to, okay. Sertraline has low levels in breast milk. It does. It's the first choice for postpartum depression, and it's probably the first choice for depression during pregnancy if somebody is treatment naive, right? The incorrect assumption was that venlafaxine should be changed to sertraline because it is safer with breastfeeding. No, we know that the international and national society guidelines say that you should encourage breastfeeding regardless of antidepressant used. The other assumption, changing the antidepressant to sertraline during pregnancy is safest. No, the safest medication is the one that keeps the woman stable, okay? Great. Tapering antidepressants before delivery decreases the risk for neonatal adaptation syndrome. There's no evidence that tapering decreases the risk. and then venlafaxine is not compatible with breastfeeding. We know that most antidepressants are compatible with breastfeeding. Okay, so switching to a case. So this was a patient that I saw. She was a 39-year-old female, married, unemployed woman from Sweden. Significant past psychiatric history, borderline personality disorder, panic disorder, depression, 7 prior suicide attempts, numerous medication trials. She said she had been cured of borderline personality disorder because in Sweden, she got like true DBT, and it did seem like it had helped her significantly. She had had 10 years of stability on venlafaxine, aripiprazole, azopiclone, Lunesta, and Klonopin. She was not under my care at this time and abruptly discontinued all medications to undergo IVF. Can you imagine? That must have been hard, right? Right? So what is her risk of relapse into depression? It's high, right? I know that this is complicated by personality disorder and things like that, but still, I would say high. Was stopping all of her medications recommended? No. Maybe we would have pared them down, right? I think if we could have combined the Lunesta and the Klonopin, great. If we could have changed it to PRN, amazing. If we could have done cognitive behavioral therapy for insomnia or like another DBT program, right? There are lots of things you can do to help people rely less on the medications. And often pregnancy is very motivating for them because most people don't want to be on medications when pregnant. She became pregnant on her first round of IVF. She had worsening depressive and anxious symptoms with difficulty eating, disrupted sleep, severe nausea, and vomiting. So again, we see these associated behaviors that also influence these outcomes, right? So she's not eating enough. She's probably not gaining enough weight. She's not sleeping well. You know, all of these things are really important. She had no psychiatrist because she previously had traveled back to Sweden every 6 months for treatment. She had worsening suicidal thoughts with plan and presented to the ER. At the ER, she had a suicidal gesture. So she went into the bathroom and wrapped a cord around her neck and said she was trying to kill herself, and she was admitted to the inpatient psychiatric unit. So which medications would you use, and how would you decide what to start in this patient? So she was started on sertraline, quetiapine, diphenhydramine, and Abilify, not based on prior response to them. So she didn't have a history of responding to sertraline or Seroquel. This is what they did. My understanding of this medication regimen is that sertraline is the safest medication during pregnancy, so they started sertraline. And I say that not meaning that true, like don't just use sertraline. I say that because there's a sense in the community that sertraline should be used over everything else. But in a patient where venlafaxine had kept her stable for 10 years, I would strongly recommend venlafaxine or duloxetine or anything like that. I keep using venlafaxine today. Quetiapine similarly is the sertraline of the antipsychotics. So people use quetiapine in the same way they use sertraline because it's the safest. And so sometimes I think that people try to kind of like blunt force patients into working on these medications, even though they would probably do better and maybe function better on different medication regimens. So that's my understanding of what they did. And then I think they wanted to avoid benzodiazepines, so they used diphenhydramine. Okay, so she was admitted to the perinatal partial hospitalization program after she was discharged from the hospital. She continued to have high anxiety and depressive symptoms, was blunted on exam. She was discharged from the PHP at 7 months gestation. She did relatively well until the California wildfires. When she would breathe in the smoke, I was seeing her at this point. When she was breathing in the smoke, she would feel short of breath, and then she'd have full-fledged panic attacks. We recommended as much postpartum support as possible. She had financial means, and so she got a night nurse and a live-in nanny, and I think it would have been very difficult for her without that support. I know that's not available to everybody. She stabilized again until 3 days postpartum, and then started to kind of have a breakdown again with worsening anxiety, intense fear of being alone, tearfulness, difficulty functioning. So we readmitted her to the PHP, and at that point, we changed her from sertraline to venlafaxine, and she's doing better. So I think there are different ways of doing it, and I think people assess risk differently. But I think it's really important to keep the patient's history in mind, and pregnancy is not the time to experiment, right? You want to use what works so that the person gets well as soon as possible. Some resources for you. Mothertobaby.org is amazing. If you haven't looked at this website, you should. I think I may have added this after the slides were printed, so I'm sorry. But mothertobaby.org. So they're patient-friendly medication fact sheets from the Organization of Teratology Information Specialists. They're great. I use them with my patients. So if I'm starting somebody on venlafaxine during pregnancy, I print this out and hand them to them and tell them if they have any questions, I'm happy to discuss it. I also tell them the information, but it's so hard for people to retain information when you're telling it to them verbally, so I print these out for them. If I get calls from colleagues asking about medications, I refer them to this website as well. I think it's great. ReproTox is much more granular. If anybody's looked at ReproTox is a big database that brings together all of the information we have on medications in pregnancy and reproductive effects and breastfeeding. So if you really want to deep dive into the data, ReproTox is where you should go. LactMed is just like ReproTox, but it is just breastfeeding. So it's just kind of all of the granular details about medications and breastfeeding. And then womensmentalhealth.org, if you're very interested in this field and you want to stay up to date in this field, MassGen puts out these like blog post articles, kind of going over new developments, new articles, ways of thinking. They have kind of a weekly email that can be really great that just summarizes all the important information that came out that week. All right, that's it.
Thank you so much. That was wonderful. You did get a compliment on your slides. They thought they were wonderful, the best they've seen so far.
My friend edited them for me, so he will be very excited.
Well, pass the compliment.
I will, thank you.
So my goodness, we got so many questions here. A lot of them were on specific medications.
Okay.
So I'll ask a couple of kind of the overarching ones,
Sure.
and then we'll just get to the nitty gritty here.
Okay.
Do you see any correlation with menarche and the onset of anxiety and depression?
Yes, generally. So I will sometimes ask patients when they first started to experience anxiety and depression, and sometimes they'll say around puberty. So absolutely. And we also know from the study that I talked about that that is when women's risk for depression goes up and elevates above what men's risk for depression is, right? So at the time of puberty, menarche, right, that the risk increases and then it stays elevated until menopause, at which point it equilibrates again. Yeah.
Great, thank you. There were a couple questions here on patients who maybe stop the antidepressant or stop their medication in the first trimester, try and stay off of the medication, but then have a recurrence of symptoms. Do they respond in the same way at that point if you are restarting the medication? Is there anything else for us to consider?
That's interesting. I think sometimes, I guess I would say, I think that in my clinical experience, it varies a lot. So I think that pregnancy, what I tell my patients a lot is that it doesn't get easier during pregnancy or postpartum. I think some people have a sense that it will fix things. And I think a lot of psychological issues that might have been dormant come up when somebody becomes pregnant. I think especially people who had complicated relationships with their families or with their mothers specifically, it can be very scary to think about becoming a mother. So I think it's not necessarily the same situation as it was before. Sometimes they do really well. And then sometimes I think that there's something new that's coming up that you're having to treat. So making sure that they have the resources and support they need.
Great. Yeah. Several questions here on TMS. Any thoughts on that?
There's some evidence for TMS during pregnancy. I don't think it's widely used or commonly available, but there are some studies that show that TMS might be helpful during pregnancy.
Great, great. What about, is that something, so one of the questions actually specified, would you do TMS before the pregnancy, hoping the effects lasted through the pregnancy? And I guess maybe that versus continuing throughout pregnancy. Any thoughts?
I think that would really depend on the patient. I think if the patient had done TMS before and had had remission of their depression symptoms for 9 months, I don't think it's unreasonable to try that. But I would say that for most patients, again, pregnancy isn't the time to experiment. And so if a patient has done well on medications, I would probably continue what kept them well. So if I were going to recommend something like TMS, it would be because TMS had worked really well for them in the past and not, I don't know if I would necessarily try that de novo.
Okay.
Yeah.
So I'm going to go through a couple of the main questions here for medications. Thoughts on lamotrigine? We got several questions about that.
I think we actually have a lot of data on lamotrigine because of epilepsy registry studies. So we have a good amount of data. We don't think, there used to be concern that it might increase the risk for cleft lip, cleft palate. Newer studies have not borne that out, so we don't think that it increases the risk for major congenital malformations. Lamotrigine levels decrease over pregnancy because estrogen induces the metabolism of lamotrigine, and estrogen just goes up, 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 up during pregnancy. So you do need to keep that in mind. So sometimes people will increase the lamotrigine levels pretty significantly during pregnancy. Breastfeeding with lamotrigine is controversial, but is being done more and more. Lamotrigine does get into the breast milk and into the infant in pretty significant amounts. There are some case reports of thrombocytosis with lamotrigine in the infant, meaning their platelet counts go up a little bit. My understanding is that that's kind of an infant stress response, that sometimes that happens. But so we would recommend monitoring platelets or monitoring blood counts in the infant. And so sometimes that limits its utility because blood draws in infants are not very pleasant. And so they would need to do that probably every 4 to 6 weeks. And then there is the theoretical concern of Stevens-Johnson syndrome in the infant, even though there has never been a report of it ever. But what frequently reproductive psychiatrists recommend is that if the infant gets a rash, you have to stop breastfeeding until you can see the pediatrician. So during pregnancy, it looks great, but it is one of the few where it's a little bit hairier in breastfeeding than it is during pregnancy. But we use it often, yeah.
Interesting. What about using, so there were a couple of questions on adjunctive medications like antipsychotics. Is there, I know you mentioned quetiapine, of course. Are there other ones that you would recommend, pregnancy, breastfeeding, et cetera?
Definitely. I mean, quetiapine is great. I think that overall we have more and more data on the antipsychotics. So similarly, we don't think they increase the risk for major congenital malformations. The main concern with them is this association with gestational diabetes. So we know that antipsychotics can cause metabolic syndrome. We know that they can cause weight gain, and so there are some studies that have shown an association specifically with the more like obesogenic antipsychotics, like Seroquel, olanzapine, that those might increase the risk for gestational diabetes. We do use them. I think that is more based on what's worked. I think we do not have very much data on Latuda, but I have seen that used during pregnancy. We have more data on the older second generation, so like Risperdal, Abilify, Seroquel, olanzapine. Those are the ones that we tend toward, yeah.
Interesting, because Latuda was always listed as category B, so everyone goes there.
But it was an absence of data, yeah.
Interesting. Lithium, pregnancy, breastfeeding. We got a bunch of questions on that.
I could give a whole talk on lithium. But so the quick and dirty is that lithium is the gold standard for bipolar disorder. We use it often during pregnancy. I know that there was some talk of avoiding it during the first trimester. I think that would be a very, very, very stable person. I think for the majority of the patients who I see with bipolar 1 who are on lithium, they need to be on the lithium to maintain their stability, and so we do continue it. So the risk of cardiac malformations with lithium is, I think, around 1 in 100, and the risk of Epstein's anomaly is much lower than that. So we do use it during pregnancy. You do need to monitor blood levels fairly frequently. Lithium levels change during pregnancy, but not really in ways you would expect. So they don't just go down, they kind of go up and down. We use it with breastfeeding sometime. It's kind of the same story as lamotrigine, where people used to say no breastfeeding, but now there are more and more people breastfeeding on it, but in a similar way, it requires monitoring of the infant and blood tests. But we do use it fairly commonly. It's a really good medication for people who have severe bipolar disorder.
Great, thank you. Benzodiazepine stimulants. I think
Let's
a
go
lot of
through
that
them
was
all.
prompted by case number 2 with the Klonopin.
Definitely, definitely. Benzodiazepines, we have a good amount of data on. If we're going to use them, we prefer lorazepam because of the clean metabolism. So it doesn't have any active metabolites and it's relatively short acting. So in my mind, benzos are fairly equivalent. So this is one of the places where if somebody's using PRN, clonazepam, I would change it to lorazepam. There used to be some concern that they increase the risk for cleft lip, cleft palate. We don't think that's the case anymore. There was one study that showed that benzodiazepine use was associated with increased internalizing behaviors in the child, which is basically like anxious behaviors. The way that we understand that is, again, probably confounding by indication, because we know that people who are going to take lorazepam during pregnancy are probably anxious, and who knows what the postpartum environment is like if they're very anxious. So I think that that's a complicated thing. But we do use them fairly commonly during pregnancy. If you were using high doses every single night towards the end of the 3rd trimester, there is a concern for a withdrawal phenomenon. But with lower infrequent doses, that's not very common.
Great.
Oh, and then stimulants. Okay.
Oh, and then stimulants.
Oh,
yeah,
yeah.
thank you.
We're getting more and more data on the stimulants as well. There are more and more studies that show that untreated ADHD during pregnancy really does affect the woman's functioning and her relationship within the family unit in ways that can be very detrimental. And so especially for like our high functioning people who need to be able to function at work, we can't necessarily take them off of their stimulant during pregnancy. So we have more data on methylphenidate and amphetamine. It's a little bit of a toss-up which one you would use. Methylphenidate showed like possible slightly increased risk of cardiac malformations, but that's a little unclear. And then amphetamines showed slightly possible worsened pregnancy outcomes. That's the main concern with them, is the theoretical concern of vasoconstriction, because vasoconstriction obviously can affect perfusion to the placenta, but we're getting more and more data on them. And so in certain cases, we are using it. They used to say that like you would only use stimulants if it was very severe ADHD. Like, are you going to get into a car crash on the way home, that severe ADHD? And more frequently, what we try to do is we try to minimize it and use it on an as-needed basis. But we are using it more and more.
Great, thank you. Do you have a recommendation if someone has new onset depression in pregnancy? If there's no history of medications, is there one that you kind of reach for?
Sertraline.
It is.
So that is the sertraline, yeah. There was a study that showed that it had low placental transfer. And people really liked that, understandably. So it didn't get in through the placenta very much, and then it has very low levels in breastfeeding and undetectable in the infant. So it is the first choice if somebody is medication naive. But if somebody's not medication naive, you have to use the history to inform the treatment.
Great.
Yeah.
If a patient comes to you on Depakote, personally, I've had 2 of these too. What is there, or when would you discontinue it? Is there a time when maybe the teratogenicity could be avoided or less severe?
Are they pregnant?
Yes.
No, they're pregnant.
Oh, well, you know what? Actually, the question didn't specify, I don't think. I imagine they're pregnant.
They're pregnant
because
on
they wanted
Depakote.
to avoid the teratogenicity. Yeah.
Well, if they're pregnant on Depakote, the damage has probably already been done since organogenesis happened so early. There's a slide that I have that shows it, but it's pretty quick. So the one thing I would say is if you have a patient is on Depakote, it is important to have a conversation with them about it, because it is a known teratogen that affects IQ and cognitive development. So in general, in countries, women of reproductive potential aren't allowed to be on Depakote, right? It's like a controlled thing. And here, if they are, I think it's important that they know that they shouldn't get pregnant, right? Or that if they that if they can take precautions, they should. I think this is a complicated issue, but they probably should be on some type of birth control or be aware that it would be very difficult if they were to become pregnant. Yeah, if they're pregnant on Depakote, that it's probably too late. So
Yeah. Um, is there a process or kind of what goes through your mind if someone has been on a medication, all of a sudden it's not working as well? Where would you go? I know it's whatever has been effective
yeah,
in the past. Is there anything else that you consider?
I think it varies a lot based on the patient, but remember that you often have to go up to higher doses during pregnancy. So one of the first things I would do is probably try to increase the dose, especially if they're in the second and third trimester. So sometimes we'll even go to higher than the FDA recommended dose because we know that the volume of distribution and the metabolism change pretty significantly. So that would be the first thing I would do. And then you have to assess, I think, if they're having any clinical response to it. Like, is it helping at all, right? So then it's the same medical decision making you make with any depressed patient who's on a medication, right? Do you switch or do you add? Because you do still want to treat the depression. So I've had times when I've augmented with Abilify or augmented with Wellbutrin, or sometimes I've switched them to a different medication. Yeah, so it's kind of the same.
Yeah, great. Thank you so much. I think that's all the time we have here, but thank
Okay,
you so
yeah,
much for your great
yes.
talk.
Yeah, thanks.